Thank you everyone for tuning in. And I want to recognize, before I start, the help I got from Peter Smith from the Institute of Work and Health. He did a large part of the analyses. And I also want to acknowledge, we don't have an official name, but I called it the COVID-19 Ad Hoc Survey Group. A bit of background. I was invited to help out with some healthcare unions that were responding to some proposed infection control procedures. And that was based on a relationship I had with these unions going back to SARS, 2009, H1N1 and Ebola. And also in 2014 and 15, we helped organize with the Ministry of Health and the WHO summit to address infection controls between pandemics. Also, watching the literature coming out of China, I noted a number of surveys were done to characterize the mental health experience of healthcare workers. And I floated the idea to the email group that was commenting on the infection control procedures. And these were some of the papers that we saw. These are free publishing versions of them. And so the members of the group that pulled this survey together were health and safety reps from various Ontario unions, and also the Canadian Federation of Nurses Unions, the Ontario Federation of Labour, and two unions in BC. Also, Guy Potter, who is an occupational psychologist with Duke University Hospital in North Carolina, helps out. He's also a member of the Copenhagen Psychosocial Questionnaire International Network. Peter Smith, as I've mentioned already. And there were a variety of interested academics and activists throughout Canada and the US involved. And from OCAL, there's Valerie Wolf and Daryl Stevenson and myself. The content of the survey starts with some of the COPSUC scales for measuring burnout, stress, and sleep symptoms, although we only used 2 of the 4 questions for each of the scales. One of the problems was trying to shorten it. So instead of the GAD-7 and the PHQ-9, we used the GAD-2 and PHQ-2 to measure anxiety and depression. We also took from the DSM-5 3 questions from the acute stress scale. We found a short self-efficacy scale that was in German and an English version of that with 3 questions. There were a lot of questions made up about exposures, and these came from the health and safety representatives from the various unions, nurses and other healthcare workers. We also used psychosocial scales from COPSUC for work pace, predictability, role conflict, supervisor support, colleague support, and we created our own similar question for family support. And from Stress Assess, we also used 2 questions on psychological health and safety climate and the culture's tolerance of behaviors harmful to mental health. We won't be talking about all the results, so we'll just be selecting some of these. The survey is still ongoing. It's about 70 questions long and takes about 15 minutes to fill out. It also allows the respondent to create their own ID code, which is easy to remember so that they can fill out the survey more than once. Early when we began the survey, we thought things were changing very rapidly, so their feelings and their experiences would probably change over time, so we allowed for that. It's also available in English and French, with thanks to the United Steelworkers for translating, and Marie-Claude Letellier from Laval for checking the translation. And these are the links to get to the survey. So here are some of the results. You can see that we launched, I believe, on the 6th of April. There were a few trial ones before then. And different unions, when they put out the message, you can see spikes. This first spike is SEIU. Later on, we had different spikes, and the last spike, I think, is OPSU. So far, you can see we've got over 4,000 completed surveys. We consider a survey completed when they got at least 70% through the survey. There's about 30% abandonment who didn't get that far. And this is a list of the unions that have more than 50 responses to date. The type of workplace, most of them are hospitals, although we have some long-term care, some community care. Other is quite large, and we still need to take some time to sort out some of the other into these categories. The size of the workplace, you can see that the most frequent is 1,000 to 5,000, but there are a fair number, almost 20% with less than 100. The province, obviously Ontario, that's where the survey comes from, and we have good coverage here, but we also have a strong showing from BC and Alberta and Nova Scotia, considering the size of the province. But over half of the workplaces are urban, and the others 20% suburban and rural. And these are the breakdowns of the actual numbers as of yesterday afternoon from the different provinces. You can see that we've got at least one respondent from every province and territory except for the Yukon. So if anyone knows anyone in the Yukon, let them know. The age distribution is a little younger than the Canadian average population. It peaks at 35 to 44, and there's quite not too many in the older. This is a bit different than we've been doing surveys in many workplaces, so it's a bit of a younger group than average. We asked a question about identity, and over 3/4 were female. Male and other were the other large proportions there. We asked questions about exposure to patients with COVID. 18%, 19% had none exposure. About 61% had at least one or more patients that they knew of in the institution. And 20% did not know. This is somewhat concerning because if you're a healthcare worker and you don't know whether there's an infected patient in your workplace, that's somewhat concerning. If they did have exposure to patients with COVID, we asked about the intensity of that, and over a third had direct contact with it. Another 5% were in the room with the patient, about 12% on the same floor, and 34% were not aware of any. 14% shared workspaces with workers who, other workers who work near or with COVID patients. We also asked a question about how many workers have been infected with COVID, suspected, presumed, or confirmed. And again, 30% none, another third at least one or more. But very concerning is that 35% don't know. And some of the comments we had in the survey mentioned how disturbing not knowing was. And there was often cited a conflict between confidentiality and the health and safety of those in the workplace. Okay, this is a bit of a complicated slide. We asked people to tell us whether they had the appropriate type or adequate supply of different sorts of PPE. They're listed on the bottom here: gloves, eye protection, face shield, gown, hand sanitizer, masks, N95 masks, or powered air particulate respirators, or PAPRs. And we're color coding this. So if they have the appropriate type of PPE and an adequate supply, that means their needs are met. The gray is the section where this type of PPE is needed. The not sure, don't know, and not applicable we'll leave on the side here. But the dark orange is those people who either have the appropriate type but an inadequate supply, or don't have the appropriate type, or don't have where it's needed and they don't have it at all. So with these, the personal protective equipment needs are the gray bar. So 95% of respondents above the not applicable needed, and 79% of these needs were met. And so you can see across the different types of PPE, you'll especially note that for N95, the difference between those who need it and those whose needs are met is the largest, followed by surgical masks, and then face shields and gowns. Eye protection is actually close behind there. So if we look at the summary of the proportion of needs met, if only 18% have 100% of their PPE needs met, and 8% have none of their PPE needs met, which is quite concerning. We also asked adequacy of preventive measures and procedures, call that P&P. And using the same type of scale here, this is procedures or measures or that have been taken, such as screening incoming patients, symptomatic patients wearing masks, cohorting COVID patients together, restricting access and controlling flow to those sections of the building where there are COVID patients, the ventilation system, airborne infection isolation rooms, personal hygiene facilities such as locker rooms, house cleaning practices, laundry cleaning practices, and waste disposal practices. And here again, you can see the difference between what is needed and how many needs were met. And the ones that were most discordant are personal hygiene, which is locker room, screening patients, which is surprising since that seems to be emphasized in various places. House cleaning, again, with infection control, that's somewhat concerning, and masks. Again, summarizing it, 16% of the procedures and preventive measures, 100% being met, and 15% not being met at all. We also asked about training related to COVID-19, and we asked people to rate their training on a scale from excellent to none at all or not applicable, and also whether they felt sufficiently trained to don and doff their PPE without contaminating themselves, and again, feeling trained and confident, or have not, to the other end of the scale, having not received such training. And you can see that for the PPE training adequacy, over half feel that it was adequate, but for COVID training, only 17%. Even the PPE training, you would expect this to be much higher in a healthcare worker population. Now, we also had selected health outcomes, the generalized anxiety disorder, GAD-2, and the patient health questionnaire, PHQ-2. And these responses were rated at not at all, several days, more than half days, and nearly every day. You can see some of the questions. Anxiety, being nervous, anxious, or on edge, not being able to stop or control worrying. The patient health questionnaires had to do with depression, little interest or pleasure in doing things, feeling down, depressed, or hopeless. Any score of 3 or higher out of these, you can see 2 questions scored from 0 to 3. If the sum of the 2 questions is 3 or higher, that's the standard cut point for screening for anxiety and for depression. We also had fear, a scale on fear, which was from 1 to 10. How would you rate your current level of fear about this whole pandemic situation? Little to no fear at all was equal to 1. 10 was as much fear as I've ever felt, and people could select between those. For concern, how concerned are you about bringing the virus home to those you live with or your friends? And 1 is no concern, and 6 is extremely concerned. And here you can see the results. These are the interquartile ranges along with the median. For the GAD2, the anxiety, over 56% of the respondents screened positive for this, and 44% screened positive for depression. For the fear question, the average was about 7, and the interquartile range was from 5 to 8. About almost 10% of people answered 10. And for concern, the average was very concerned, and 6 is extremely concerned. So it was most people were at the top of the scale for concern. So this is a regression evaluation, which had looked at what would predict anxiety by their personal protective needs met, and also the policy and procedures needs met. So on this side here, we have the personal protective equipment. So if people said they had 100% of their protective equipment needs met, the adjusted anxiety score would be 2.7, which is below the 3 cut point. And this is adjusted for gender, age, facility type, province, population density, whether it was urban or rural, experiencing symptoms, told they have contact with the patient, COVID training, and PPE training. So if part of their needs, 50 to 99% of the needs are met, it was 3, and it goes up to 3.4%, 3.47% for none of their PPE needs being met. You see a similar trend for policies and procedures, and it crosses the cutoff line at 1 to 49% of their policy and procedure needs met. For the general anxiety scores, by training adequacy, again, we see that's slightly under the cutoff point for COVID training being adequate, and over for COVID training being inadequate. And PPE training is pretty well right at the cut point for adequate, and inadequate just slightly over. So the difference isn't as strong here as it is for the PPE needs not being met. And these are the same type of analysis, except for the outcome of the fear score. And again, by PPE and policy and procedure. And you can see a similar trend. The more the PPE is met, the lower the fear score. And the difference between 100% and 0% is more than 1 point in the scale. Similarly, for the policies and procedures, the difference between 100% met and 0% met is slightly under one point of the scale. And for the training, here again, we can see a bit larger difference in the fear scores as we saw in the anxiety scores, both for the COVID training and again, a smaller one for the PPE training. These are statistically significant, and I'm not sure whether a quarter point on the scale of 1 to 10 is statistically significant. And I understand that some of my friends from the COPSUC International Network might be online, so I dedicate this slide to them so they can see we asked about burnout, stress, and sleep symptoms, although we only used 2 questions instead of the 4. And we used the short scales or core scales for work pace, predictability, role conflicts, supervisor support, colleague support, and family support. We have national averages to compare to. However, this population is highly selected, so I'm not sure how valid the comparison to the general population would be in this case. We also asked people's opinion about how these different parties in the workplace are doing in protecting the workers in the workplace. For the union, 57% agreed or strongly agreed that the union is doing its best. This drops down to anywhere from 35 to 40% for employer, government, and health and safety committee or representative. The health and safety committee being the lowest is somewhat concerning. And that's a theme, I think, that has been in the news a lot. Who these people are, 95% of them are members of a union. 2.6 did not tell us whether they were or not. They left the question blank. Another 2% were non-union members. Some people weren't sure if they were, and some people were unwilling to say. Okay, as I wrap up here, I want to show you some data from the Public Health Ontario. They put out an epidemiological summary every day, and from it you can figure out what percentage of all people testing positive in Ontario are healthcare workers. And as of yesterday, 14.2% were, or 2 days ago, April 29th, 14.2% were healthcare workers. However, in hospital outbreaks, of the people testing positive in hospital outbreaks, just slightly over half of them are healthcare workers. And in long-term care facilities, about 1/3 of those testing positive are healthcare workers. Compared to Ontario's 14%, China had a 4.4%. And when China was faced with this situation early on, they started off with 20 to 30% healthcare workers being the proportion of the positive tested. They stepped up their protective equipment to Ebola type protection. So a lot of it was triple layers. And after that, of the 42,000 healthcare workers who volunteered to go to Hubei for during the pandemic, not a single healthcare worker was infected. And so you can see how Ontario is comparing to the experience in China. And it doesn't take a rocket scientist to come to the conclusion, whatever we're doing, it's not working. So what can be done? Well, the hierarchy of controls, which people in health and safety are quite familiar with, says you should start with trying to eliminate the hazards, substitute engineering controls, administrative controls. And I found this paper that was recently published. It was written before the pandemic, but it gives a nice breakdown of some of the ideas on what to do for each one of these: elimination, substitution, engineering, etc. I won't go through them one by one, but if you're looking at the slides later on, perhaps it might be a bit of a template or checklist to look at. What about those people who are stressed? As I said, over 50% of these people who responded screened positive for anxiety, and over 40% screened positive for depression. And there's a group in Ontario called the COVID-19 therapist.com who have a website, and they are providing pro bono consulting services for healthcare workers who have been impacted by COVID. And you can click and connect with somebody, and they can direct you to it. And there's, I think, maybe almost 1,000 people who have benefited from this service already. The last thing I want to mention is that we have a survey of non-healthcare workers' experiences going on right now. The survey was adapted from the healthcare workers survey by Dorothy Wigmore, Laura Lazansky, and Alec Farquhar, and run past the COVID ad hoc survey group. It's similar to the healthcare survey, but it's designed to capture worker experiences during the pandemic, those both working in workplaces and those working at home. And if you'd like to access this survey in English or French, these are the links. And at this point, I thank you for listening. And if there are any questions or comments, I'm trying to figure out how to turn this back. Stop sharing. Okay.
Thanks a lot, John. I think we'll ask people to put any questions in the chat box. There are some comments here. Dorothy has mentioned that in order to do that level of analysis of the PPE and fear, it shows that we need a bunch of the questions answered to get a real picture, and it makes it worth getting through the whole survey. If we can encourage people to do that, send them a tea bag or something like that so they relax and have time to answer all the questions. I don't know if there's any lots of positive, that it's very informative. Do you have comparisons to other countries other than China, for instance, Scandinavian?
Yes. Yes, in Italy, the early days, again, it was very high percentage, but once they tightened down on the types of protection they were wearing and up the standard, it was down to 9% of all positive cases in Italy were healthcare workers. In the United States right now, it's lower than our 14% also.
Okay, and I think there had been a question earlier that I maybe missed. So when anybody has a question, I think oh, it was a question more around how are the figures about healthcare workers getting the virus accurate? Okay, how do we know?
These are numbers that were that are published every day from the Public Health Ontario. So these are people who have been tested and tested positive. So ask Public Health Ontario if they're accurate.
Okay. This is a question more around is the relation of healthcare workers to confirmed cases variable across the provinces?
I looked for that information, but Ontario seems to be one of the few provinces that are counting the number of healthcare workers infected as a separate item in their updates. The other provinces may be counting them too, but they're not putting them on the internet that I can find anyway.